protection plan in case the board starts to smack you around a little bit. You have scientific evidence that what you're doing is correct. Can you hear me, Chris? I'd like to introduce our next guest speaker, who is a personal friend of mine, Dr. Thomasson. He's from Colorado. He has a very busy head and neck pain clinic there. He does a lot of TMJ work. He's just started to do more cavitations. This gentleman came up the hard way, harder than most people I know. He used to be a coal miner in the hills of West Virginia. If you look at his tummy, he has what's called the West Virginia abdominal area. That's all paid for, by the way. And now he's a very successful dentist specializing in head and neck pain. The device he's going to show you today and the research he's done on this is the anodyne machine, which I think some of you are familiar with. I have had one for several years and have had great success, from an aunt who broke her neck to a dog that had a patellar injury, and on problems that I've had myself. Tom has been playing with this infrared energy for almost 10 years now and doing research. His wife exposed him to this about 10 years ago, and he's taken this and run with this and had an incredibly effective tool for us in the dental and medical professions. Without further ado, Dr. Thomasson. Tommy, come on up here. I need to put this on you, okay? Here. You know, if you buy more expensive coats, they have pockets that work, you know?
Costco.
I like it. I'll give you 20 bucks for it.
Okay. Is that working? No.
No, you have to plug into this.
Okay.
That's getting taped. Right?
I have to do two things at once?
Yes, sir.
Okay.
All right.
I'll do my best. Thanks, Chris. Certainly appreciate the opportunity not only to be here, but also share some information with you that I've become interested in recent past, especially because of Chris Husser's gracious mentorship. I've been using the anodyne infrared system for pain primarily and post-TMJ surgical healing. And when I got involved in the osteonecrosis situation, I began to institute a protocol with my patients where I would insist that they would use a home system 8 weeks after each surgery, 1 hour a day minimum. I've had phenomenal increase in success rate. I can report in the past 2 years doing that, I have not had post-op infection, and I've only had one site open up after surgery, so I've been pretty excited about that. But what intrigued me was the responses I'd seen with Alex's out here, his heart rate variability machine, also the brachial artery elasticity tests I would see at some of the conferences I went to, both testing before and after application of photoenergy. And the results that I saw seemed to indicate to me that there was some heavy metal detoxification or dumping or some sort of process going on. So in light of that, we'll make sure, I got my watch, make sure we get out in time for lunch. I want to start out with a little uplifting moment for you, or not. It's important. I know Chris really agrees with this. In any event, I'm having a little bit of trouble with this remote mouse, so I may have to stand down here. Sure. Just hit this one right there. We're dealing with the photonic spectrum, and in this particular case, 890 nanometers. Pulse repetition rate of 292 pulses per second, 50% duty cycle, in the near infrared range here. Okay. Photoenergy does interact with tissue. Go ahead and hit it 3 more times. We know plants convert carbon dioxide to oxygen. We have melanin production in our skin. And we have color recognition through light-gated ion channels in our eyes, where we have wavelength and energy density dependency. We have to have the right energy density in the room. We have to have the right wavelength to be able to recognize color. Some of this, many of you have already seen. I'm going to go through it pretty briefly and very short just to give a baseline for some of you who have not seen the physics behind what's happening at the molecular level. Next. Characteristics of interaction. The wavelength dependency is the Grothus-Draper law. Only light which is absorbed can act chemically. If it's penetrated through the entire tissue, there will be no photochemical interaction. And there's an energy dependency, as we mentioned earlier, in the color recognition. Wavelength and energy dependency. A photochemical change is also proportional to the energy intensity and the time of the illumination. The optimal interaction characteristics would be perpendicularity to the treatment area. We need to be in contact with the treatment area because light does degrade as a product of distance. We need an appropriate energy density and a uniform and homogeneous delivery system. We don't want hot and cold spots, not necessarily temperature, but in energy density. This is a professional system I use in my office. The next slide is the home system that the patients take home with them and treat after surgery. The mechanism of action is specifically releasing nitric oxide produced by a nitric oxide synthase 3 or constitutive nitric oxide synthase. The wavelength and energy density is specific to break a bond at the cysteine position in hemoglobin, the beta chain. And the nitric oxide is released from a sulfhydryl group in the hemoglobin and also in the endothelium lining of the lymphatics and the blood vessels. This is the only known therapy to affect nitric oxide without ingestion, injection, or physical activity. And nitric oxide is found in hemoglobin, the endothelial cells of the blood vessel walls and the lymphatics, and in cellular nitrosothiols, sulfhydryl groups and nitrogen oxide combinations. There are three forms of nitric oxide synthase. BNOS, or brain nitric oxide synthase, is not just found in the brain, but that's where it was discovered, so that was the term originally given to it. It's now more commonly called NOS1 or nNOS, neurotransmission NOS. The second form is inducible nitric oxide synthase, or NOS2. It's an inflammatory type. CNOS, or the constitutive form, NOS3, is really the good guy. This was originally called endothelial-derived relaxation factor. It's important if you read anything about nitric oxide in the literature to know where that nitric oxide was produced. If we don't know which synthase produced the nitric oxide, we're not really going to be able to determine if it's a good thing or a bad thing. Too much nitric oxide from NOS2, or the iNOS form of the synthase, will cause an inflammatory reaction. CNOS, or NOS3, will downregulate that inflammatory problem. These two x-rays led to the discovery of the mechanism of action. This sequestrum resorbed in 48 days and the periosteal separation was healed. But more importantly, bone density increased about 30% in 48 days. These are very controlled, done out of UC Davis. The only way this could have happened, according to the physiologist at the University of Colorado School of Medicine, was a release of NOS3-produced nitric oxide. How do we know we are specifically releasing NOS3-produced nitric oxide? Doppler flow increases just minutes after application. Plasma nitric oxide, seconds after application. Plasma nitric oxide increases minutes after application. And for iNOS, next, produced nitric oxide, it takes hours for a cytokine or an inflammatory insult to produce a level in the blood that's detectable. This is a Doppler analysis that was done in a lymphology conference at Puerto Rico. These are 5-second intervals. This is dorsiflexion of the foot. The infrared pads were applied to the lower leg. This is a baseline evacuation after dorsiflexion of the foot 3 times. At this point, the pad was applied to the leg, and you can see an increased evacuation within 1 to 2 seconds. The second time, we hit dorsiflexion and applied the pad here, and you can see an increased baseline evacuation during the entire relaxation process. This can only be achieved with NOS3-produced nitric oxide. The way that peripheral capillary evacuation occurs, and also lymphatic evacuation, because this device does dilate the lymphatic duct diameter, and it does so in this manner. Just put the mouse in the middle of the picture. Okay, don't go back. No, just. Blood pressure is regulated by NOS3 produced nitric oxide as well. The pulse, and in this case demonstrated by the coronary artery, physically releases nitric oxide. The Nobel Prize for Medicine was awarded in October 1998 for the discovery of nitric oxide regulating blood pressure. We see the lumen of the coronary artery. We very often will get atherosclerotic plaques built up, and then we go into a spasm or angina pectoris. To offset that, nitroglycerin tablets are given, and the spasm relaxes. This mechanism is exactly how the photoenergy density and wavelength creates relaxation of the lymphatics in treatment. Acetylcholine attaches to a receptor site. At that time, nitric oxide is released, and being a gas, it goes in all sorts of different directions. It just permeates the tissue. It interacts with guanylate cyclase, dephosphorylates guanate triphosphate to cyclic GMP or monophosphate form. Myosin's inactivated and the muscle relaxes. It's exactly how muscle spasm relaxes in skeletal muscle and how we dilate lymphatic diameters as well. Next. Take the arrow out of the picture and hit it. Take the arrow out of it. There you go. In rat plasma, radiating with the infrared device gave us a level of 12 micromoles of nitric oxide released. In saline, with red blood cells, taking the red blood cells out of the plasma, we got the same amount of release of nitric oxide. We took the hemoglobin out of the red blood cells and then irradiated them again. As you can see, we got almost no nitric oxide released. This led us to the conclusion that the hemoglobin was the primary source of nitric oxide. Next. With one pad applied, we got 8% increase in nitric oxide. With two pads, we got a 28% increase. So it was exponential, not geometric. I'm not sure where the endpoint to that is. We haven't done additional tests on multiple pad placements. This study led to National Jewish Hospital in Denver doing an asthma study. This nitric oxide level in an asthmatic is too high. It's produced by iNOS or NOS2, the inflammatory form. We applied the pads on either side of the sternum, and as you can see, it downregulated about 50% of the inflammatory response. It's extremely effective in asthmatics. Non-asthmatic, non-smoker, very little change, which is exactly what we should expect. Nitric oxide synthase 3 produced nitric oxide is a modulator, not a stimulator or an inhibitor. So here's our mechanism. Near infrared, endothelial cells and red blood cells, irradiated, releasing nitric oxide produced by NOS3. It's antiviral and antibacterial as well, which may help explain why I haven't seen the post-op infections. Nitric oxide synthesized by activated macrophages inhibit viral proteases that process viral polyproteins. It's not really virucidal or bactericidal, it's more virostatic and bacteriostatic. I did some blood studies about 4 or 5 years ago, and I found that we got a 400 to 900% increase in monocytes and reactive lymphocytes within 20 minutes, placing the pads over the jugular area and doing anticubital draws at 0, 2, 5, 10, and 20 minutes. That leads us to more macrophage activity from the monocytes, better debridement of the tissue, and also reactive lymphocytes becoming plasma cells, therefore becoming B cells and T cells, so improving the immune response as well. Move the mouse into the picture. Many of you have seen this previously. This horse was scheduled to be put down. It had injured itself as a champion barrel racing horse. The only thing that was used was the device every day for 20 minutes, and in 6 months there was actually new epithelium, new hair growth, no scarring, and it returned to barrel racing. This was the original research before going to the VA hospital to do some venous stasis ulcer studies. Next. Same thing, move it into the... This was the first venous stasis ulcer that was treated. It had been under treatment for 13 years. They had had skin grafts, platelet-derived growth factor, regranics, hyperbaric oxygen, everything had been done. This has a less than 3-second capillary refill time, It has angiogenesis and neurogenesis. There's new blood vessels and new nerves in this tissue. I'll show you a laser Doppler analysis on perfusion in just a moment as well. Next. This one was on the leg for 40 years under treatment at the VA hospital in Denver. These patients treated themselves at home, 20 minutes a day, debridement occasionally. Move the mouse into the picture. None of these wounds have broken down. And I'm only aware of one wound that hasn't healed in 6.5 years of using this on these types of wounds, and that's on the heel of a gentleman who refuses to quit wearing his cowboy boots. But we all have our values, I guess. I like my cowboy boots too. Next. This is just an example of 3 different types of wound on the same foot. Post-operative wound dehiscence, pressure ulcer or decubitus ulcer on the heel from being in a wheelchair, and a stasis ulcer on top of the foot. Here's the same sutures you see over here. 3 different types of wounds, all responded in the same manner in about the same time frame. This gentleman doesn't have to be without his toe. He was scheduled for a great toe removal at Denver General Hospital. Instead, the foot surgeon there, who was the second healthcare professional to ever use this on patients, treated him with the system, and you can see the result. And to this day, he still has his foot. We actually regenerated new tissue and blood vessels and nerves. Next. Example of scleroderma healing. 4 months, unresolved, 2 weeks, complete resolution. The pain decrease, which is one of the benefits post-surgically that I see, occurs through COX-1 and prostaglandin H2 and prostaglandin I2. Primarily, we have an immediate decrease in swelling through the dilation of the lymphatics that you saw earlier, so we have less pain just from the physical impingement on the nerves. We get better oxygen and nutrients and glucose to the nerve so it can repolarize and get from negative 30, 40, or 60 millivolts back to negative 90 millivolts where it should be, so it doesn't fire as easily. And nitric oxide also inhibits non-cholinergic and non-adrenergic nerve firing. With tissue remodeling that you saw occurs through the COX-2 pathway, cyclooxygenase pathway 2, and prostaglandin E2. There's a nuclear transcription factor that's activated through COX-2. This nuclear transcription factor is NF-kappa B, and it promotes 2 early response genes, CFOS and ERG. Studies are in place on bone and muscle. Clinical results show neural remodeling as well. We now have a study, which I'll share with you in a moment, on diabetic neuropathy, so we do know we're getting some neural regeneration. We do get angiogenesis as well. That occurs through platelet-derived growth factor. Platelet-derived growth factor does not produce more platelets. It produces more blood vessels and the endothelial lining of those blood vessels. Nitric oxide is responsible for the reticulocyte to differentiate into platelets in the first place, and then again responsible for the multiplication of the platelets going from 2 to 4 to 8 to 16. So there's a dual fold effect with nitric oxide in producing more platelet-derived growth factor. It also decreases platelet adhesion, which is a real big plus in these osteonecrotic patients, especially the 80% that are suffering with the hypercoagulability genetic problem. This is the laser Doppler perfusion study I mentioned earlier. This wound, after healing, actually has better perfusion in the tissue than the tissue that was never injured or wounded in the first place. There's better blood vascularity and better blood flow in the healed area. Next. This is a blow-up of that little graph at the bottom. It's a 3-fold increase in perfusion over the tissue that was never treated. We get neurogenesis. Diabetic neuropathy study just completed last month at Columbia Health One Hospital. 48 of 49.
Down. Okay, great. Sorry.
48 of 49 patients responded in 2 weeks with improved sensation on a monofilament test. 49 of 49 improved in 4 weeks, and 65% of those had their protective sensation returned. It's pretty dramatic. This has never been shown in medical literature before. Because of this study, there's 2 more major universities who are going to continue the research into this. So we have neurogenesis, or we have reactivation, remyelinization. That's what we need to find out with more research. The Alzheimer's disease connection. Boyd Haley shared last year at his conference that mercury and cadmium, among others, binding to sulfhydryl groups in the Alzheimer's patients were responsible for much of the condition. We've noticed that treating the venous stasis ulcers on nursing home patients with Alzheimer's, often in 5 or 6 weeks, would start to reverse the condition. They would begin to remember their appointments, they would remember their therapist, what happened at the last appointment, some family members' names, and so forth. It was anecdotal. It wasn't something we were looking for. But further research demonstrated that there's also a nitric oxide deficiency in Alzheimer's patients. The sulfhydryl groups bound to heavy metal are responsible for transportation of nitric oxide in the body. So the nitric oxide can't get to where it needs to be if it can't hook onto a sulfhydryl group, whether it be on a cysteine or methionine. Taurine is not really the same type of stereoisomer that we need, but the sulfhydryl groups are essential to transport nitric oxide for these things to occur. It's my belief, and those that I've talked with at major universities, that the reason we're seeing these tremendous effects by releasing nitric oxide from hemoglobin is because we're bypassing the toxic mechanism that's supposed to be transporting the nitric oxide in the first place. By releasing the nitric oxide, and it being such a small gas, it can permeate the tissues without having to be transported, again, by the sulfhydryl groups. Next. Even in the absence of oral heavy metal toxicity, as all of you I'm sure know, there's plenty enough mercury in the vaccinations that we've received and in the environment and some of the fish and other parts of our diet to still create the problem. Next. So our pretreatment benefits that we've talked about: less inflammation, bacterial activity, viral replication, less platelet aggregation leading to more platelet-derived growth factor, increased osteoblastic activity. Those x-rays that I showed you earlier of the increased bone density came out of work with NASA, trying to reverse osteoporosis in astronauts. Russian astronauts do not get osteoporosis in space, only American astronauts do. And the reason is the Russian astronauts breathe compressed atmospheric air, so they get about 20% nitrogen. American astronauts breathe compressed oxygen only. But they haven't changed it because it's too expensive to compress atmospheric air, according to NASA. So tax dollars at work, folks. Angiogenesis we talked about, and more lymphatic evacuation. Next. Our post-treatment benefits are the same. They should be. We want the same thing to happen in a non-surgical or surgical situation. Next. This particular case is what led me to start looking into some of the things that I'm going to share with you today. This 40-year-old white female came to my office. She had had her metal removed and her dental revision done 2 to 3 years before. The only thing that she had that she wanted done was to have 2 root canal teeth removed, number 14 and number 30. I'll show you some photos of them in a moment. She had a baseline 24-hour urine of 5 parts per billion prior to the removal of the 2 root canal teeth. The day after removing those teeth and cleaning up the area around them, her 24-hour urine mercury level went to 18. I thought, what is going on here? Where did the mercury come from? Did I stir it up in the bone in the area where we did the surgery? Did we allow her to detox a lot easier because of various energy fields and meridians and so forth being in a healthier condition by getting those teeth out of there? I didn't know. I suspect it's a combination. Next. This is her Panorex. You can see the 2 teeth. By typical standards, those are pretty normal looking. That's an oxymoron. Fairly normal looking root canals. When I took this one out, there was a perforation into the sinus about the diameter of a number 2 pencil without doing anything else but taking the tooth out on the palatal root. Next. This is overexposed, I apologize, but there's really not a whole lot of indication or radiolucency around the root tips of these teeth that would be the standard of evaluation whether the tooth was in fact healthy with a root canal or not. Next. Again, this is overexposed, I apologize, but we have the same situation here. Next. So I did some urinalysis. I did a 24-hour baseline, kept diet, fluid intake, everything the same, and then before the second 24-hour collection, I did 2 hours of infrared treatment over inguinal and jugular areas. Here's the results of that. The first 24-hour collection was 1,500 mLs volume. The second 24-hour collection was 4,300. There was no additional intake of fluid. This was interesting to me too. Before the infrared, the heavy metal testing, these are the only ones that had a change. Pretty significant numbers. And the only thing that was done was applied jugular and inguinal areas of the infrared pads for 2 hours. Next. This lady came in with the same request. She wanted dental revision and removal of root canal teeth. And you can see a little piece of mercury here in the tissue. Next. It's pretty significant bone destruction. She had a clean mouth. She didn't have any periodontal disease. So how can that be explained if there's not some sort of reaction going on here destroying bone? We talked about earlier that bone can only be laid down if nitric oxide upregulates osteoblastic activity. The nitric oxide is competing for mercury for a sulfhydryl group to do what it needs to do. I don't have an answer. Anybody can jump in anytime you want, but my suspicion is that we have this competition, so we've got increased osteoclastic activity because osteoblasts are not upregulated. Next. This lady, as Chris would say, according to the medical profession, has a Prozac deficiency. Bless her heart. You can see she's got plates in the maxilla. She's got wires here where she had surgery back in 1983. She's got a mouthful of metal. She's had brain surgery for trigeminal neuralgia to put a sponge in to relieve pressure on the nerve intracranially. She's had 3 temporomandibular joint surgeries. I mean, wouldn't it be nice to get these folks first? And my heart goes out to her. I mean, her whole life is a wreck. But in any event, you know, we just have to keep getting the word out to at least some of these other colleagues to do some differential diagnosis before they jump in and look at the whole world as a nail because all they have is a hammer. Next. This is a close-up of the SAVE X-ray. You can see the wires still in here, and then this was done for orthodontic purposes. Next. This is very interesting to me because this is a 16-year-old girl, 4 impacted wisdom teeth. These are bony impactions on the bottom. When I took these out, I sent them to Jerry Boco. One of the mandibular molars came back normal, which you kind of would expect them both to come back normal. The other one had already started pulpal hyperemia, congestion, and degeneration. This tooth hadn't even erupted yet. I would expect if we do some tests with her with Dave Berg at HEMEX that we'll find some sort of tendency toward hypercoagulability. That's just a supposition on my part. Next. I couldn't find anything really wrong with this lady. But my rent was due, so I could have made up a treatment plan anyway. Is that unbelievable or what? Look at this. This goes all the way up through here. She's I don't want to step on any toes, but she is 35 years strict vegan, has never had any animal protein in almost 4 decades. I talked to Jerry Bacot about it, and he felt that you often see a gelatinous type of bone in people who are starving. And again, I don't want to step on anybody's toes, but there are those who feel that animal protein is necessary for healing and proper tissue development. She came to me and wanted to do everything she could to keep her root canals. She's in the fashion industry. I'm not making this up. Her brother's a dentist in Austria, so we got that going back and forth. It's been a real interesting case. We've already cleaned this area up, and also went up into this area so far. But she had an implant here, and she was upset that she rejected it, and I said, well, that's great. It's a good thing you did. You can see the sclerotic bone that was left. Next. Here's some close-ups of some of these teeth. Some of dentistry's finest, huh? I'm not trying to point fingers, and I've made a lot of mistakes, and I'm going to share some of them with you today. Just don't want to keep making them. Next.
For those of us that aren't dentists, could you describe what you mean by some of dentistry's finest?
I was being cynical.
I know you're being cynical, but I mean, I've seen a lot of dental x-rays, but I've never seen anything like this.
If I told you who the dentist was that did this, 80% of the people in this room would recognize the name. I will not do that, but
No, I'm not asking that. What has happened to these teeth besides
she went in for cosmetic dentistry, and she had some porcelain veneers and then some porcelain crowns placed. And they basically, my opinion is, this happened over a period of 30 years. They probably fried the pulp. She may have been predisposed to it because of other environmental and dietary regimens and conditions. But even by normal root canal standards, if there are such things, I don't know, George, did you used to do those kind? Did your root canals look better than this, George?
Tom, I think what she's referring to, she doesn't really recognize the fact that those are overfills, that there is a degenerative process going on at the apex of those teeth, because not being a dentist, she wouldn't realize that we don't want to put all that material, I don't want to put it in the tooth, let alone out of the tooth in the jawbone. And that's what's wrong with the procedure there. Either the overfill has occurred or there has been a degeneration or resorption of the tooth itself around there, causing the inflammation of the bone and disease process to continue. I think that's what she's referring to.
Yeah, these are, I mean, it's tremendous overfill and or resorption externally. Go back to the previous x-ray if you would, please. Well, you can't, this is a little too bright. But these are extreme overfills, a tremendous amount of bone degeneration here, a lot of osteoclastic activity, probably anaerobic organisms at work. If not, then certainly osteonecrotic event that Jerry Bacot describes is at work as well. Okay, next. Next. These are normal values for the changes that occurred in this lady. I took part of her bone when we did the surgery and sent it to doctors' data and had them analyze the bone for heavy metal, because I'm trying to figure out why that initial patient I showed you had such an increase in heavy metal, especially mercury, after doing surgery in a non-metallic mouth. These are normal values. Next. These are the 3 outside the norm values. Can you go back again? I don't know what this means, quite frankly. I'm just throwing this out there for food for thought for all of us. In fact, I only got this information at 7 o'clock this morning. Dean Bass faxed it to me, and I put it into the presentation because I just sent it off about a week or so ago. But there is heavy metal in that bone. Next. This gentleman came to me and wanted an opinion on what he should have done. I gave him an opinion. He, which is okay with me, went someplace else to have most of the work done and then wanted to come back later and have the restorations done. So he went someplace else and had the surgery. I have 2 periapicals to show you. I don't really have the follow-up pan with me. But you can see where the tooth roots used to be, typical osteonecrotic areas. Next. See this root? Here's where the other 2 roots were. There's 3 roots on this particular upper tooth. That's after they did surgery on him. That root tip was probably, 3/4 of a centimeter. It was unbelievable. He had a tremendous sinus perforation. When I opened that area up, it basically just almost fell out of the area. So he went through all this surgery, and this is what he was left with. And he went to somebody who was supposed to be in a position to know what to do. Again, I'm not trying to point fingers. I think it's important that we can't stop sharing this information and doing research so we can get some good information out there. But this, to me, is blatant malpractice if he did not inform the man that it was there, and he didn't. The fact that he couldn't get the root tip out is one thing, but at least send him to somebody who could. Next. You can see another piece left down here on the bottom. And again, this is a pretty well known practitioner that did this work. Next. This lady went to the same person. This is after her treatment. This is how she was left. This tooth's bad. Tremendous necrosis up here. Sclerotic bone. This is after she was surgerized. Next. This lady came to me from a city in Colorado. Can you see the dark area here this tooth is infected. It's dead. And this one. This dentist was rebuilding her mouth. The fee was $28,000 to rebuild her mouth for her. These are the temporary bridges he had already placed. And he fully intended to go ahead and restore the rest of those teeth in that condition. And we wonder how people get in such a mess. It doesn't take a very well-trained eye to see that there's dark areas around these root tips. 72 years old. Next. Next. Do you see these restorations up here? They seem to be within normal limits. We have a big cavity up here. But you got a lot of bad looking bone in areas that don't really look like they've been badly restored or had a whole lot of dental work. Next. Pretty amazing story, isn't it? This lady had 2 tetanus injections in '96. She was forced to have a second one or they would not let her graduate from medical assisting school. She went in a coma for 8 days after the second tetanus injection. Since then, she had been diagnosed with severe asthma. She was on 23 prescription drugs daily. This made the front pages of Fort Collins newspaper. In fact, if any of you are interested in a copy of the article, you can stop by Rocky Mountain's booth and they have the newspaper article available for you. This was just what the insurance paid. Doesn't count the 2 refinances of their house and all their savings. She had written letters to her children because she thought she was going to die. Next. This is what her mouth looked like. One half of her mouth was done under intravenous sedation, basically extractions of root canals and removal of metal. Then the other half was done 6 days later. The day after the second appointment, she's never had an asthma attack since, quote unquote. She's not taking any medications at this time. She was taking one of the 23 for a while. She has not had a nebulizer treatment since that was done, and she was on a nebulizer every day throughout 24 hours a day. About every 2 to 3 hours she'd have a treatment. This area here with all the amalgam particles is a huge amalgam tattoo. It's about 6 centimeters by 1.5 centimeters on the lower right side. When you touch the bone over the amalgam tattoo, you can just feel a big depression where it sinks into the bone, where the bone's been destroyed. Next. You can see the amalgam particles here.
Tom, were those in the bone or were they in the soft tissue?
They haven't been removed yet. This is very recent. But I'll let you know when the dentist who does it tells me. Next. I really don't like sharing this, but I got to share it with you because I really messed up. I really hurt this patient. You can see the amalgams in here. This was a TMJ patient that had TMJ surgery and was sent to me after the fact to do orthodontics. Well, I was out of composite brackets and I had some old stainless steel brackets laying around. So what did I do? Did I reschedule her? No, I put the stainless steel brackets on. 6 weeks to the day after I put those on, she woke up and couldn't move her right hand. Her anti-nuclear antibody titer, ANA titer, which should be 1 to 140, went from 1 to 1280. She came back in, had these braces on her wrists and so forth, walking with a crutch. I asked her what it was and what was going on, and she told me, and my heart sank. So I asked her if I could take the brackets off. She said yes. In 5 days, her ANA went down to 1 to 160. From 1 to 1300 to 1 to 160 in just 5 days. Now I hope and pray that this is reversed. I don't know. You know, as one of our colleagues quoted in one of his books, all things may be preventable but not necessarily reversible. I hope that she reversed out of this rheumatologic condition. Next. For those of you who are not in the dental field necessarily on a daily basis or familiar with these conditions, this lady came to me and you can see the remnants of where a tooth used to be. She had had 2 root canals over here and had them extracted. She came back from a camping trip and had a root canal finished the day she got back. She had lost 40 pounds in 2 months. I suspected a couple of things. I mean, I knew this infection was here, but I also thought perhaps she'd gotten Lyme's from a tick bite. So I sent her for evaluation of Lyme's. I told her that she needed to have surgery on this area. She was in severe pain. She had severe stomach pain as well. She went to her physician to get checked for Lyme's. It came out negative, but she didn't do a 6-day by-accident study. He sent her to a gastroenterologist because he wanted to make sure that the stomach pain was benign in a sense, that there was no tumor or malignancy. Very reasonable thing to do. The gastroenterologist did a endoscopy of her stomach, didn't find anything, and told her quite frankly that there was nothing wrong with her and she needed a psychiatrist. This is a sad story. She left his office, went home, and got a gun and blew her brains out. These are serious, serious cases, and we just take them very lightly. Even I find myself sometimes not really taking them as seriously perhaps as I should. This lady lost her life because somebody in the medical field was flippant with her. Just because he didn't find something, that meant there was nothing wrong with her. At least he could have said, just, your stomach's normal, keep looking. Next. Good old Uncle Sam. This is what I want you to see got fixed. These are patents. I have copies of them being sent. This is a patent on herpes HHV6. See the assignee? Government of the United States of America, Bethesda, Maryland. Interesting, huh? Next. Methods of detecting the presence of human herpes virus 7 infection, another patent. Next. Here's a page from inside that patent. It is an object of the present invention to provide a new herpes virus. Your tax dollars at work. Check this next one out. Pathogenic mycoplasma. It's patented. 1991. Next. Usually when I try to present information, I try to do it in a very orderly fashion and lay things out and build a foundation and come to a conclusion. I really couldn't do that with a lot of this stuff. So I hope that by sharing some of these cases and some of my observations, that it's been beneficial to you. I don't have any conclusions at this point. I'm still gathering information. If any of you have additional information on these areas as to where maybe these metals are hiding and harboring and what pathogens might be involved in a symbiotic relationship, I'd certainly love to hear about it. I intend to do a study on hypercoagulability incidents in these patients with multiple sites, and then perhaps even with the cooperation of a physician, use heparin on some of these patients, either pre or post-surgically, gather tissue, send it for metal analysis, do toxicity analysis, urinalysis. Try to make some more sense out of some of these things. I got the greatest amount of respect for so many of you here. But we need to share information not only with ourselves, but as much as possible with other people in the field. If we could get some heat off, and I think Charlie Brown's going to help us with that. Are there any questions? Yes?
You can patent anything you want to nowadays. Especially within the biotech, DNA conversions and genetics. These companies are scrambling for it. They have patented grains now. And you could have a form of wheat with 3 or 4 different patents, and it's all genetically altered wheat. And it's a theory that's making us sick because our body doesn't recognize it anymore as normal wheat that we used to have 100 years ago. You mean to interrupt?
No. These HHV6, HHV7, and mycoplasma were developed. I found out about these patents from Dave Berg at Hemex Laboratories at an International Oxidative Medical Conference back in February. And then Bob Jones was kind enough to search them out and print them out. And as I said, they're being shipped. I'll have, if you want a copy of them for any reason, I'll have them here probably tomorrow, maybe later today. Yes, there was a question, Becky.
How do you think infrared sauna does a lot of the same things, only, of course, albeit slower rate?
I like the infrared sauna. I intend to get one at some point for myself. But talking with Johnson and so forth, my understanding is that it's working on a radiant heat generated by infrared, far infrared. This device is warm, but without the warmth, it does exactly the same thing. The warmth was built in order to get FDA clearance in 1994 and a CPT code, which it has. If you take the warmth out of this device, it still does all the same things, but it wouldn't have been 510K'd. So one's radiant heat, the other's pure photoenergy. Yes?
How deep will this penetrate into tissues? Like, could one use it on for angiogenesis in bummed up heart patients with bad congestive heart failure, for example?
You could, because the important thing is not penetration, it's absorption. When this photoenergy is absorbed in the hemoglobin and the endothelial linings of the blood vessels and the lymphatics, and nitric oxide is released, nitric oxide is a free radical and a very small molecule. It permeates the tissue, just as you saw in the animation earlier. So nitric oxide is what needs to penetrate the tissue. The device is effectively just precipitating a series of events by releasing that nitric oxide in the first place, but only releasing the non-inflammatory and non-neurotransmitting type, based on the research to date. So we've got, it's much more important if all of it was absorbed in the peripheral capillary bed than if all of it penetrated all the tissue. So you will get the effect even systemically. I had one patient I treated 13 times in the head, neck, and face area who was on 39 units of insulin. Over a period of 10 weeks, she cut her insulin back from 39 units to 18 units. 2 years later, with new blood tests, all her blood proteins were normal. What happened is that she was type 2 diabetic. Nitric oxide produced by NOS3 is the precipitating factor to activate the beta site in the pancreas to release insulin. She had all the tools she needed, she just didn't have a starter. That happened before we really knew what the mechanism of action was. I just, in my country boy sort of way, thought she was chewing better and eating better and felt better. Yes, Chris?
Isn't your wavelength different than the infrared sauna wavelength?
Yes, it's near infrared. It's almost visible, whereas the far infrared sauna is on the much further end of the spectrum of infrared.
Are your infrared wavelengths found in the sun?
Interesting question. It wasn't known. This was invented in 1992. The guy that invented it was angry because his father lost his foot, leg, and life to diabetic ulcers. He's driving down the road, pulled over, wrote down a wavelength, pulse repetition rate, duty cycle, and energy density. Didn't find out till 6 years later that that combination of events was specific to break the bond of nitric oxide and hemoglobin. Also found out about 3 years after it was invented that if you measure the infrared wavelengths, or all the wavelengths coming from the sun, when you get to 890, there's a dip to almost zero, and then it immediately comes back up. I have no idea why. It was another coincidence in this whole project, but that particular wavelength is severely blocked by the atmosphere. I don't know why, I just know that it is. Yes?
I think that just gives, excuse me.
That's exactly what I was thinking about. The sun. Many years ago, I was a pediatrician, and we used to put babies in the sun to cure their bilirubin problems. Do you think this has anything to do with this spectrum?
I don't know. I just find it very interesting that that this particular wavelength is so restricted by the atmosphere, and I'm not sure what part of the atmosphere restricts it. Yes, sir.
Is it possible to have too much exposure to this wavelength?
It's not possible to have too much exposure because the effect is to release nitric oxide. You will only release that which you've endogenously produced. So you can't release and utilize any more than you've already produced. So it's self-limiting in that respect. You can't really over-treat with it. When you have things like Viagra or nitroglycerin tablets or nitroglycerin salve, you're releasing nitric oxide also, but it's dosage dependent for the patient. And so there's a lot of problems and side effects that occur with those drugs. Johnson & Johnson has worked on a nitric oxide inhaler for asthma for years. But again, the problem is they don't know how to adjust the dosage for the individual.
You can increase the dose by putting it in different parts of your body.
Yes, sir. Yes.
Who sells the equipment?
Rocky Mountain Health Technologies, these two ladies in the back of the room in red and brown, they have a booth out here. Carol Rana has been using it for quite some time, and she swears that it takes your bad chi and turns it into coochie coochie. Any other questions?
How many people have these? Who has that?
There's quite a few people in the room that already have it.
What are you doing here? They know
I don't know.
Could have got somebody else.
Well, you asked me out and I said yes.
Tom, you're so easy.
I am so easy and cheap too.
Any more questions for Thomas?
Thank you very much. I really appreciate it.
Good job.
Kind of a rambling little presentation.
Yeah, it was kind of random.
Well, I didn't know where to go.
We're going to meet, we're going to take a lunch break now. I encourage you to visit our exhibitors. There's some great exhibits here. We're going to meet back here at 2 o'clock for a power charge talk by Charlie Brown, who was with Swankin and Turner, talking about the lawsuit against the American Dental Association for the mercury issue. I encourage all to be here at 2 o'clock. For your lunch, you're on your own. And living here in Reno, the greatest place to eat is downstairs at the buffet in the back, Toucan Charlie's. When I eat there, I cripple them very badly. But they have a wonderful dessert bar, they have shrimp, they have everything else. So downstairs, the best buy in town is the buffet in the back, okay? Otherwise, there's a coffee shop in the front, and I think that's probably all you need. Otherwise, you're on your own. Any questions before we break for lunch? Back here at 2 o'clock, please. Tommy, thank you, good job.